Okay, so ladies and gentlemen, welcome back to the Gadjah Mada International Conference on Tropical Medicine, GAMA-ICTM 2025. Thank you so much for your anticipation. Then hopefully you already enjoy your lunch, and in a few moments we will join for the second symposium that discuss about challenges in vaccination for strengthening resilience against tropical disease. Sorry, Rima.
Yeah, you just like testing me a bit. Thank you very much. But before that, we would like to once again inform you that this GAMA-ICTM 2025 focus on strengthening health system resilience for tropical disease control in a rapidly changing world, with special emphasis on the transformative power of digital health and the urgent need for health equity. We would like to thank you, our sponsor, Takeda Pharmaceuticals, ITS Science Indonesia, and this GAMA-ICTM 2025 is part of the annual scientific meeting, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada 2025.
And also we would like to express our gratitude to our media partner, Media Indonesia, Republika, Harian Jogja, Star Jogja FM, RRI, Bakri Center Foundation, and also Kedaulatan Jogja.
And here we come, the second symposium of the second GAMA-ICTM 2025 that will talk about the challenges in vaccination for strengthening resilience against tropical disease. This symposium will be led by Professor Mei Neni Sitaresmi.
And let's take a look of her profile. At that time, she was the Community Service Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. Currently, she is active as a lecturer, researcher, and a pediatrician in Growth Development, Social Pediatric, Child Health Department of Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, and also Dr. Sarjito Hospital, Yogyakarta, Indonesia. She is also actively as a member of International Society of Social Pediatric and Child Health, or ISSOP, and International Society of Pediatric Oncology, or SIOP. And also she is actively as a member of Indonesian Task Force on Immunization and also Indonesian Technical Advisory Group on Immunization.
So without further ado, ladies and gentlemen, please welcome Professor Mei Neni Sitaresmi.
Thank you, the Master of Ceremony, Mas Yopi and Mbak Rima, for the nice introduction. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. I think this is not a very nice time, but it's very interesting topic, because in the second symposium, we will discuss about the challenges in vaccination for strengthening resilience against tropical diseases. I think it's very, very important and also interesting topic because we know that the vaccination has been proven to be one of the most effective preventive strategies. This is also the most success story in the public health intervention because we know that vaccination saving millions of lives every year, especially for the vulnerable population such as children. And alhamdulillah, due to the effective vaccine, smallpox, or we call variola, has been eradicated. And polio is close to be eradication. When I was in the Puskesmas, and it's around maybe 13 years ago, the eradication already launched, and at that time, I think it will be achieved in the, not like this moment, And however, despite of the launch of the Global Polio Eradication Initiative in the 1988, I think it's more than 30 years ago, complete eradication has not been achieved. So we will learn from our first lecture, Professor Olakunle Alonge, MD, Ph.D. from the University of Alabama at Birmingham, And he will present the global effort in polio eradication, listen, learn. And for the second session, the second lecture, we will learn from the Prof. Nicholas Grassi from the Imperial College London, because he will explain about what is the future for oral vaccine. Because compared to the injectable vaccine, oral vaccine are easier to administer and also more affordable, is because it's more cheaper and often more acceptable, not only from the parent but also from the head worker. So it will improve the compliance. And also another advantage of the oral vaccine, it also induce not only from the systemic immunity but also the mucosal immune response. However, challenges remain, and especially for the low middle income country like Indonesia, because we still have many enteric infection that may impact the effectiveness of oral vaccine. And finally, the last session, Ibu Hashta Meyta from the Ministry of Health Indonesia, she will present the strategies and challenges in the strengthening vaccination coverage in Indonesia. So we will begin to our first section, Professor Olakunle Alonge. Prof. Kunle, hello, good night.
Hello. Good afternoon.
Oh yeah, this is good afternoon, but in your time it's already midnight, right?
Yes, it's past midnight here.
Okay, so we are very appreciative for
Hello, can you still hear me?
Yeah. Okay, sorry for the
Good.
technical problem. So we are very appreciate your time, because in spite of you already in the midnight, you still aware and willingness to share your experience, especially in the polio eradication. Yeah. So before we proceed on your presentation, I would like to introduce you, and please share from the his CV, maybe in the okay. Yeah. So Professor.
Okay.
Yeah. Professor Olakunle Alonge. Sorry for maybe I'm mistaken for spelling your names. Yeah. You are the professor of the Department of Health Policy and Organization in the University of Alabama at Birmingham. And also recently you are the director Sp.A Center for Global Health, and also the Scientific Center for Clinical and Translational Science in the same university. So now without further ado, the time is yours, and you will present 20 minutes. Yeah.
Okay. Yeah, sure. Thanks a lot for the introduction, and it's really a pleasure to be with all of you. And I'm trying to share my screen. Can you see my screen? Good. So good afternoon to everyone in Yogyakarta, and it's really a pleasure to be with you. Today I'm going to be talking about polio and some of the lessons that can be learned from the polio eradication effort. And to kind of start the conversation, I think it's important to first revisit what makes an infectious disease or an infectious disease agent to be eradicable. There are some criteria that we kind of look for when we think about the goal of eradication and infectious disease. Obviously, there is the characteristics of the pathogens, which includes the fact that there should be no non-human host reservoir for the pathogen, and as well as there should be some effective strategies, including vaccine, to address the pathogen. So, and I think this is really the first place to begin to learn from the polio eradication effort. So indeed, polio is only found in human reservoir, in human host, and indeed we have an effective vaccines for polio. But that is not all that it takes to eradicate a disease, and that's something we've learned in a very hard way in polio, in the polio eradication effort. Beyond just having this scientific characteristics in place and vaccines in place, we also need political will. We also need funding. We also need solidarity and social support, across different levels, global, national, subnational, region, and so on. And I think the absence of some of these other ingredients can impede the eradication effort. And that's really something we have learned. So that the fact that you have vaccine does not mean people would receive the vaccine. The fact that the disease agent falls within the criteria that is eradicable does not mean you'll be able to succeed in the eradication effort. And that's really a lesson for other activity, other attempt to eradicate an infectious disease agent. Just some brief background about the pathology and the pathophysiology and some of the pathogenesis of polio. We know that it's an RNA virus. The polio virus is an RNA virus. It belongs to the enterovirus subfamily, and basically there are three Y types: type 1, type 2, type 3. Enterovirus in the sense that it is majorly transmitted through the fecal-oral route, that is through fecal contamination of food and water, and is sometimes found in respiratory secretion. And one of the things that it does in certain individuals when it infects, it causes severe damages to the spinal cord, a predilection for the gray matter of the spinal cord, and which actually affects the motor neurons and can cause debilitating paralysis. Incubation period is between 3 to 5 days. That is the period between the infection and the first onset of clinical manifestation. It's transmitted again from fecal contamination, gets from there, from the GI, from the gastrointestinal tract into the blood, and then from there it gets to the nerves, where it attacks the nerves and the spinal cord. So some of the clinical manifestation, why I'm bringing this up is because, this disease, a lot of us, we've been around so long that we've forgotten what polio looks like. I mean, we just hear polio because of the success of the eradication effort and the vaccination effort. We don't see the clinical manifestation of polio. But trust me, polio is still a very debilitating disease. It's still a very impactful disease. It's about 72% of individuals that are infected, it's the disease is inapparent. That is to say, it doesn't have any clinical manifestation. But in a very small proportion of people, you could, in about 1 to 100 or 1 to 500, you could actually have paralysis after the infection, and typically the paralysis affects the lower extremities. It usually affects the legs more than the upper extremities, and sometimes you could have instances where it affects the cranial nerve that supplies some of the functions of swallowing and other things, and which can really, even breathing, that controls the intercostal muscles and so on, which will actually lead to bulbar polio, which is often very fatal. Now, in terms of how to combat it, like it has been said earlier on, we have two very successful vaccines. One is obviously the inactivated polio virus, which is a killed version of it's a killed virus. The virus is completely inactivated within the vaccine, and this actually induces, because it's given through injection, it does not have any, it does not elicit any gut immunity. That is, there is no mucosal antibody that is produced as a result of inoculation with this vaccine, but it produces serum antibodies, so therefore it's able to fight against the pathogen that is found in the blood, but not necessarily what is found in the gut infection. The oral polio virus, on the other hand, still have the live virus, even though it's attenuated, that is significantly weakened, that it cannot have or cause neurological disease, and because it is given through the oral route, it can induce mucosal antibody, that is antibody within the gut where the infection usually first takes root, and from there it can also induce antibody in the serum as well. So it kind of protects against both the gut infection and the neurological disease. And this characteristics of the vaccine really is important, because you can imagine that that's one of the reasons why the oral polio virus has been the mainstay for the eradication effort, because it confers immunity for the patient, or for the individual that receives the vaccine. And because these individuals are also secreting through fecal matter, they are secreting some of these viruses, they are shedding some of the viruses even in the environment. So it kind of helps to confer some community level immunity. And that's why it's really one of the it's actually a mainstay for the eradication effort. We have the trivalent OPV, which contains which can actually protect against the three white type viruses, type 1, type 2, type 3, and then we have the bivalent, which has type 1 and type 3. And then we have the monovalent for type 1 OPV, monovalent OPV type 2, monovalent OPV type 3, which is specific for each of the subtypes. Now, just to say that the trivalent, has been discontinued. It's no longer in use, and the reason is really because in around 2016, the white polio virus type 2 was indeed eradicated globally. So there was really no need to continue to circulate the OPV. To continue to use the type 2 the OPV2. So most of the OPV viruses that you will see in use now really is the bivalent, or either of the monovalent for either of the subtypes. So since 2017, we, along with our colleagues from Gadjah Mada and other universities, have been looking at some of the innovations and the strategies that have worked in polio eradication, and trying to configure those strategies for other public health programs. And some of the lessons that I'll be deriving today is from that project. So it's a project that consists of partnership across 7 to 8 universities in different countries of the world. And this partnership, which we call STRIPE, has really been very instrumental to some of the eradication efforts in the African region. It has been very helpful in identifying implementation strategies in different countries, including Indonesia, and facilitated the translation of those strategies to continue to strengthen polio eradication effort, and as well as other public health programs. There are at least a couple of lessons that we were able to determine from that effort. One, of course, is really around the way the program was initially set up. So the goal to eradicate polio virus was set up in 1988 with the end goal set for year 2000, that is to say, and this was really based on, as of 1988, the expanded program on immunization was really very successful. About 50% of developing countries actually have sufficient vaccination coverage. But somehow along the line, we kind of missed the ball, because rather than to continue to sustain the immunization system and the expanded program on immunization, the polio program was actually removed from the expanded program on immunization, and it was set up as a parallel program. And that has implication for the sustainability of the program. It also has implication for the immunization system in a lot of countries. So there was a lot of parallel system, which was a major criticism of the Global Polio Eradication Initiative. And it was not until recently that efforts began to be made again to make sure that the polio vaccination program is well integrated into the broader immunization system, and to strengthen the health system in the developing countries. And that was actually one of the reasons why the stakeholders group called the corporate partners for the GPI was expanded to include Gavi, in addition to the original 4, which later included the Gates Foundation, who were key stakeholders. So that was, again, another key lesson. So again, the first lesson is the fact that you have a vaccine in place does not mean that you can eradicate a disease. The fact that you have a vaccine in place, the fact that it's only found in a human host does not mean that you can eradicate the disease. There are other things. There's a lot of social factors that you have to consider. So of course, it's the willingness, it's the political support, it's the solidarity across different levels, is the funding, the advocacy, and all of those other implementation strategies that would accompany the vaccine. And again, the second lesson that we have learned from here is that you have to think about sustainability from the beginning. So you can't set up a vertical parallel program and expect while that may take you across a particular success level, on the long run, for it to be sustainable, things have to be integrated within the health system. And I think you should think about that from the get-go. And some of the implementation strategies that were identified for the polio program, I mean, depending on the phases, between the 1988 and early 2000, there are a lot of planning strategies around agenda setting, mobilizing resources, advocating at the global level, at the national, at regional level, national level, or subnational level, which kind of paved the way for the 4 pillars of the Global Polio Eradication Initiative. So what are the 4 pillars? One is routine immunization. That is to say, you want to routinely immunize children and have coverage above 80%. And then the second is supplemental immunization activities, that in addition to having a robust system in place to routinely immunize the children with polio vaccine, you also want to have activities including mass campaigns, national immunization days to supplement the immunization effort. And of course, the third pillar is around surveillance, both acute paralysis surveillance and environmental surveillance. So looking at, remember that we said that just a very few cases comes down with paralysis. So if you see one case of paralysis, then it gives you an insight into the level of community transmission that must have taken place. And even you don't want to wait to see the paralysis for you to know the transmission level or the transmission rate. We're looking at CWAS, looking at other environmental samples to make sure that there are no viruses. I mean, to kind of get a sense of the extent of the spread of viruses within an environment. And of course, there's targeted mop-up campaigns where vaccinators go from house to house to immunize every children. So that was really the mainstay of the implementation. Those are the mainstay implementation strategies between 1988 and 2012. Then from 2013 onward, there were again additional effort to certify different regions, to think about containment, and then to switch from OPV to IPV as different continents were being certified and different wild types polioviruses were being eradicated within human populations. So just to give you a sense of where things are, so we know that almost all of the WHO World Health Organization region has been certified wild polioviruses free as of 2024, except for the Eastern Mediterranean region, where we still have wild poliovirus type 1, which is still endemic in Pakistan and Afghanistan. So what this means is that wild poliovirus type 2 and type 3 has been eradicated, right? Wild poliovirus type 2 and type 3 has been eradicated, but we still have wild poliovirus type 1 still endemic in Pakistan and Afghanistan. And this has implication because wild poliovirus 2, type 2 and 3 has been eradicated, so there were strategies around removing the wild poliovirus type 2, the OPV2 from circulation, because there is yet a risk, that the virus in the vaccine, in the oral poliovirus vaccine, can actually still increase the chance of infection and continued transmission of polio. And we will see how this kind of played out shortly. So, what are some of the other key lessons to consider? One is that eradication efforts requires very careful planning and coordination. And again, things are happening dynamically. So the science also must be catching up to the context. And I would explain what I mean by that. And again, because the context is also dynamic, it's not just a clinical disease, it's a social disease. There are social determinants of health, there are structural determinants of health, there are policy environment that is rapidly changing that we have to be responding to in real time. There are social upheavals, that we have to be responding to in order to be able to be successful in the eradication effort. And community engagement is key in places where the polio vaccination program has succeeded. It's really because community has banded together and effort has been led at the grassroots to mobilize families, to mobilize different individuals from different walks of life, which continues to be a key ingredient for success of the eradication program. And of course, you should know that because it's such a complex, yeah, it might look simple that you have an infectious disease, you have a vaccine, but it's such a complex entity because you are dealing with human behavior, you are dealing with changing context, you are dealing with different culture and so on. And so again, to keep an open mind as you go on with the eradication effort. So what are some of the other lessons? So again, I've kind of drawn the lesson about attention to not just the science, but actually making sure that you have the political support, the political will in place. I've drawn attention to the lesson around in thinking about integration from the beginning, not setting up parallel programs, but working within the health system to strengthen immunization program. But there are additional lessons to kind of think through. So one was around when there was a switch from the trivalent OPV to the bivalent OPV, and with the anticipation that because the white poliovirus type 2 has been eradicated, that we could remove the trivalent OPV and then just focus on bivalent OPV that covers type 1 and type 2. But what we did not anticipate at that time was that we didn't have adequate supply of the inactivated polio, the IPV vaccine. We didn't have enough supply to go around the different communities. So what now happened was that there was some gap in coverage in different communities in different parts of the world, which actually then gave room for the virus in the OPV type 2 that was in circulation to kind of revert back to some virulent state, and that's vaccine-derived poliovirus, and that eventually led to infection by the vaccine-derived poliovirus type 2, which we call circulating vaccine-derived polioviruses, and which is now one of the major challenges that we are having in terms of achieving the eradication goal. So again, I think anticipating that because you've eradicated OPV or you've eradicated white poliovirus type 2, careful planning should have gone into the effort to switch from the trivalent to the bivalent, and ensuring that we had enough capacity and enough resources in place in order to be able to supply the IPV that will replace some of the OPV vaccine. So what happened was that switch actually kind of set us back in some regard, and a lot of the countries now had to revert back to the OPV instead of using the IPV, and it was all very messy in a lot of places. So again, anticipating and planning ahead is really key, even though you have different strategy, and some of these different type of vaccines plays different roles. And these are some of the other impediments to the use of the IPV vaccine in developing countries.
Prof. Kunle, sorry, to remind you that the time only 5 minutes left.
5 minutes left. Thanks a lot. I'll wrap up. So as I begin to wrap up, just to give perspective again, so most of the challenges that we're having now with the circulating vaccine-derived polioviruses, based on some of the things that I've talked about, and this is really just a spread of places in the world where we have currently reporting circulating vaccine-derived polioviruses outbreak. That is, we have cases of acute paralysis as a result of vaccine-derived polioviruses, majorly type 2 and type 1. So again, we should have thought about this and we should have carefully planned about it. So again, what's the role of science? Because of this, the science we're beginning to look at novel OPV type 2, which are genetically more stable, that are now in use, and now we're hoping that that would actually help to carry, to address some of the challenges with the circulating vaccine-derived polioviruses. And of course, there are other issues around the context and being responsive to strategies in real time. We are all familiar with what had happened in Afghanistan, in Pakistan, in Nigeria, where conflicts and civil unrest and competing political agenda was hampered the vaccination effort. And here the key lesson is really around community engagement. It's really around the power of talking to people at the grassroots, the power of engaging, and overcoming mistrust and fatigue within the community. And similarly, we have stories from the Republic of Congo and in Ethiopia, where again the emphasis is on really systematic assessment to map contextual challenges, assess program readiness, and be ready to implement addressing other community needs. Particularly in Ethiopia, there was a lot of lesson around integration from the get-go. Even though most other countries were setting up parallel system, in Ethiopia, they had actually structured it in a way that it was strengthening the primary health care, which was actually helpful in carrying the eradication effort forward. And of course, in places like Indonesia, there are issues around geographical inaccessibility. We have multiple islands, and then to coordinate multiple systems within the islands to sustain the immunization program was a challenge. So again, there were instances of the need to engage the community, the need to mobilize the community, and there was also effort around micro-planning, enumerating population, so that you can be able to identify those that needs to be vaccinated, and also using different types of technological innovations to be able to identify pockets of population that should be eradicated. So again, that should be vaccinated, sorry. I know my time is up, but just in summary, to emphasize again that polio is still a deadly and debilitating disease, and we still need to push forward with the eradication effort. And yes, we have made a remarkable progress in an effort to eradicate polio globally. It's only endemic to 2 countries now, but we have continued challenges with the circulating vaccine-derived polioviruses, and we really need to muster all of the effort to push to the finish line. And yes, both OPV and IPV have their role to play in the eradication effort. And of course, I've listed some of those challenges and some of the lessons that could be learned from those challenges. Thank you.
Okay, thank you very much, Prof. Kunle, for very insightful presentation. Okay, yeah, because now in your time is in the midnight, so we decided there is no question for you. But of course, if any question raised from the participant, we will send the question to you by email, and please maybe answer through the committee. So thank you very much for Professor Kunle. Big applause for you.
Thank you.
Good night.
Good night. Thanks a lot. Bye-bye.
Yeah. Bye. Yeah. Okay. Okay, so now we move to the second speaker, Professor Nicholas Grace from the Imperial College London. Okay, good morning, Prof. Nicholas. Can you hear me?
Good morning or good afternoon.
Oh yeah,
Can you
good
hear me?
afternoon for Indonesia. And in your time it's still, okay, it's still in the morning, right?
Yeah,
Okay.
still dark here.
Still dark. So thank you very much for your willingness to share your experience. I will go, yeah, because maybe. Yeah. Okay, I think it's better if I stand here. Okay. Thank you very much because you are still in the dark situation. It's very morning, and you will give your presentation about what is the future for oral vaccine, right? This is a very slightly change from the initial topic. Yeah. Okay. Yeah. Like I mentioned before that oral vaccine, there are some beneficial compared to the traditional such as injection vaccine, yeah, because it's more easy to be given and also is, yeah, maybe more cheaper and affordable and also maybe more acceptable both from the parent and also from the health worker. So it will improve the compliance and also it not only induce for the systemic immunity but also mucosal immunity. However, still some concern risk. Yeah. So when I look for example, for the rotavirus vaccine, because the efficacy in the like a developing country like Indonesia is even lower than the more developed country, maybe due to the some, for example, the common infection from the gastric. So maybe it also will decrease the efficacy of the vaccine. So we will learn from your topic. And before you present your slides, so I will introduce your, please, okay.
Should I stop sharing my screen? Sorry.
Okay, yeah. So yeah, Professor Nicholas Grassi, you are the professor of the Department of Infectious Disease Epidemiology, Imperial College London. And you also the head of the Vaccine Epidemiology Research Group and also the co-lead vaccine team, MRC, Center for Global Infectious Disease Analysis. So for yours. And you have 20 minutes for the presentation.
Great. Thank you very much for that introduction. And I hope I'm not going to repeat. It sounds like you've already discussed something about oral vaccines, but hopefully what I present is complementary. Can you see my screen now?
Yeah.
Wonderful. Okay, so I wanted to talk about what is the future for oral vaccines. So we have just 3 available licensed oral vaccines targeting poliovirus, rotavirus, and cholera. And those vaccines are in routine use in tropical countries in routine immunization programs. We just heard from Prof. Alonge about oral poliovirus vaccine and the different products available there. He also mentioned the novel serotype 2 monovalent OPV, oral poliovirus vaccine, which is manufactured, as you know, in Indonesia by Biopharma. And that is a genetically more stable vaccine, less likely to revert to cause outbreaks of vaccine-derived poliovirus. We also have 4 WHO pre-qualified oral rotavirus vaccines and 4 pre-qualified oral cholera vaccines as well. There is a live attenuated oral typhoid vaccine, Vivotiv, but that's not WHO pre-qualified or used in routine immunization. It is only available for travelers. Great. So when we look at the routine immunization schedule, and I've just brought up the one here for Indonesia, oral vaccines are in a minority. Most of our vaccines that we administer are injectable, but they do have important properties, as you mentioned, and they do continue to be used. So that's why I wanted to talk about what's their future. Are we going to see a phasing out of oral vaccines, or do we need to continue to rely on them? So why use oral vaccines? Well, firstly, they're easy to administer. So for the polio program, being able to have people who are not necessarily healthcare or trained in healthcare administer vaccines, giving 2 drops orally, allows the program to conduct mass immunization campaigns that have been highly effective. But perhaps the key feature of these vaccines and the reason we need them is that they induce a true mucosal immune response in the intestine. So I won't go through the details, but on the right there is an example for poliovirus. There is an induction of a class-switched IgA response, and that production of dimeric IgA can effectively target mucosal intestinal pathogens, leading to their neutralization and transcytosis across the intestinal epithelium into the gut lumen. So it's an effective, true mucosal immune response that is required to protect against infection at the intestinal surface. And also likely to be important for protection against gastrointestinal disease as well. So we already heard about the impact of the Global Polio Eradication Initiative. So through the use of, largely through use of oral poliovirus vaccines, the number of countries endemic for poliovirus has really shrunk down to just now Afghanistan and Pakistan. And also important to note that the number of serotypes of poliovirus that still circulate have gone from the 3 that were present when the world committed to eradication in 1988 to just a single serotype now of wild type poliovirus now circulating, and that's serotype 1. Likewise, for oral rotavirus vaccines, over the last 20 years, we've seen countries introduce these vaccines into their routine immunization programs, and over time, coverage with those, or in fact, actually quite rapidly, coverage has increased in those countries. I think Indonesia made the decision to introduce rotavirus vaccine in 2022. This map here is for 2023, so it just captures that beginning of that introduction. And I suspect coverage is now much higher than what's shown on this map. Those countries in grey are places that are yet to introduce rotavirus vaccines. And in those countries that have introduced oral rotavirus vaccine, you see a really significant impact on disease. So on the leftmost bar in this plot here, you can see on average a 70% reduction in rotavirus hospitalization in the time following introduction compared to before introduction, and a substantial impact on any cause acute gastroenteritis or AGE hospitalizations and deaths. So both these vaccines are really having major health impact and benefits globally. But as we heard just now, just in the introduction to this presentation, these vaccines don't perform equally well in all settings. And in fact, we see a declining trend in vaccine immunogenicity and efficacy with increasing levels of poverty. So as we go from high income settings to lower income settings, we can see that the vaccine efficacy against severe rotavirus gastroenteritis declines. This is a graph on the left summarizing across studies of all oral rotavirus vaccines. And we see a similar pattern for the oral poliovirus vaccine as well, with lower seroconversion, which is an immune correlate of protection against disease for polio. So this has been a challenge. And what that means is that the impact of these vaccines is less than what we would like, particularly in the settings where the burden of disease is highest. So on the left now is that same graph of vaccine impact on rotavirus hospitalizations, but this time grouped by child mortality strata. So you can see in countries with high child mortality rates, the reduction in rotavirus hospitalizations following the introduction of oral rotavirus vaccine is less compared to low child mortality countries, in other words, high income countries. So the impact of oral rotavirus vaccines is less than what we would like. They're still having a very beneficial impact, but there's still a significant residual burden of disease. And in fact, rotavirus remains the leading cause of severe gastroenteritis and diarrheal death. On the right here, I've just plotted recent case numbers for polio. And as again highlighted by Prof. Alonge, whilst there has been a decline in progress against wild-type virus, that virus is continuing to persist. And one of the main reasons for that is that we need to give many doses of the vaccine to achieve seroconversion because of its lower rate of seroconversion in low-income settings, including in Pakistan and Afghanistan. And also we've seen this increase in the number of vaccine-derived poliovirus cases. So that's where the vaccine strain in oral poliovirus vaccine can mutate and revert to become transmissible and cause poliovirus outbreaks. And of course, now we do have that novel product, which is now being widely used for serotype 2. We don't yet have products for serotype 1, which is the remaining wild-type virus. But that new product produced by Biopharma is significantly more genetically stable. But it doesn't completely remove the problem of vaccine-derived poliovirus strains, which have now been reported linked to the use of that vaccine as well. So why do live attenuated oral vaccines perform less well in low-income, high-burden countries? Well, there are many different factors that could potentially play a role and have been hypothesized to play a role. I don't have the time to provide details on all of those, but this slide just summarizes that those may occur before birth, in the infant, before vaccination, around the time of vaccination or post-vaccination. Some of the leading hypotheses or ideas for why these vaccines are less effective relate to exposure to other enteric pathogens and the high burden of enteric disease. That means that when you vaccinate with an attenuated strain, that attenuated strain is unable to itself replicate and induce an immune response. But if you want to learn more, you can look at that paper. Perhaps related to this lack of a good understanding of the mechanisms of poor performance, many different studies have been conducted to try to improve oral vaccines. But what you'll see from these graphs here is that most of those studies, the effect size has not passed 1. So in other words, there's no evidence that these interventions can improve the effectiveness or the immunogenicity of these vaccines. I will just highlight, hopefully I can use a laser pointer one moment. Yeah, so hopefully you can see my laser pointer. By decreasing the number of serotypes in the oral poliovirus vaccine, so going from trivalent to bivalent or even monovalent products does increase the rate of seroconversion for the serotypes that are retained. Also giving extra doses, which has been the main way that the Global Polio Eradication Program has addressed that challenge. For oral rotavirus vaccines, again, there have been a whole series of interventions to try to improve the immunogenicity of those vaccines, from withholding breastfeeding to giving an extra dose at birth, giving probiotics. And perhaps the only one really where we see evidence for an impact is where the first dose is delayed. So instead of giving it at the first DPT contact, giving it at the second, seems to offer some benefits. But the overall, these studies haven't really found a consistent way of improving the immunogenicity of these vaccines. So what do we have as alternative if we can't improve the performance of these vaccines? How can we address that residual burden of rotavirus disease? How can we improve vaccines against other gastrointestinal pathogens? Well, the obvious target or product would be to use an injectable vaccine. This graph here on the left shows a cost-effectiveness analysis for injectable rotavirus vaccines. Were those products to be available? So generally, if those products were at least as effective or more effective than oral rotavirus vaccines, given their cost, they would be less costly and have greater impact. So that's shown here with these cloud of points here compared to existing licensed oral vaccines. if those vaccines, one advantage of an injectable vaccine would also be the ability to use that in a combination product with routine antigens like DPT. And there is indeed a robust pipeline for injectable rotavirus vaccines. So this is a slide I took from a presentation at WHO PDVAC at the end of last year. And you'll see there's a pretty healthy preclinical vaccine product, injectable vaccine product development pipeline, and that's recognizing this residual burden of rotavirus disease. Some of those have gone into phase 1 and 2, but what you also see is that only one has made it through to phase 3. And in fact, there's a sort of no entry sign there, and that's because that trial was unfortunately stopped. So in the phase 3 study of that injectable rotavirus vaccine candidate, it provided inferior protection against severe rotavirus gastroenteritis compared to licensed oral vaccines. In the study, that was the Rotarix vaccine that was used. So the question is, why did that happen? Why did we get to a phase, or why did the sponsors get to a phase 3 and the vaccine fail? There was good evidence from the phase 2 study that this vaccine could protect against rotavirus infection and shedding. So a key way of assessing new vaccines is to use human challenge. So in this case, the Rotarix live attenuated strain in Rotarix was used as a challenge agent, and then shedding in stool measured at 5, 7, or 9 days after that challenge. And you can see here in this graph on the left, in the placebo arm, you have shedding at a rate of around 45% of challenged participants. And that rate of shedding declines modestly in those infants who were immunized with the injectable non-replicating rotavirus vaccine that was assessed in that phase 3 trial, with the greatest reduction seen at the highest dose. So the phase 2 data did show good immunogenicity and also protection against shedding of this challenge virus. The collaborators at the Center for Infectious Disease Research in Zambia also did a human challenge study more recently. And in this study, they were able to compare shedding after challenge in infants given the 3 doses of the injectable non-replicating rotavirus vaccine and compare that with shedding after 2 doses of Rotarix, the standard of care. And you can see that Rotarix vaccine does provide substantially better protection against shedding after challenge compared with the non-replicating rotavirus vaccine. In that study, we also looked at combined schedules, trying to see if combining Rotarix with the injectable vaccine improved protection. But because we didn't see any additional benefit from the non-replicating injectable vaccine, those study arms also did not show any additional benefit in terms of a reduction in shedding compared to the Rotarix vaccine.
Prof. Gracie, sorry, your time is still only 5 minutes left.
Thank you, yeah. When we look at poliovirus, we also see that the injectable poliovirus vaccine, which we know does provide great protection against paralytic disease, also does not offer great protection against infection and shedding of poliovirus in stool after challenge. So this is a study conducted a little while back comparing infants who had received no previous type 2 containing vaccine challenged with type 2 OPV compared to those who'd received 2 doses of injectable vaccine. Not really any difference in the level of in the proportion shedding after challenge compared to those who had received trivalent OPV, and you see a huge reduction, a huge impact of that oral vaccine on protection against shedding. However, if we compare the children who received IPV to those who received no vaccine, you can see that there is a reduction in the shedding index. So that's a measure of the mean logged viral titer shed. So there's a reduction in the duration and the quantity of virus shed after challenge, even if the proportion shedding is not really affected. But of course, that reduction is minimal compared to the reduction seen after 3 doses of oral vaccine. So there's some suggestion that both injectable rotavirus vaccines and injectable poliovirus vaccines can reduce level of shedding and level of infection after challenge, but the impact is much less compared to oral vaccines. So do injectable vaccines prevent community transmission of gastrointestinal pathogens through this small effect on shedding? Unfortunately, there's very limited data and mixed results to date. So with polio, we have very limited experience with countries that have any poliovirus circulation using IPV-only schedules. So most countries would use a combination of IPV and OPV. So we have little data, actually, despite years of use of IPV, of its potential benefit in preventing community transmission of poliovirus. For typhoid, we do have injectable polysaccharide and conjugate vaccines available. And we have essentially mixed results in terms of the potential impact on transmission. There have been a number of cluster randomized trials. Some of those have indicated herd immunity. This one on the right was a study that did show herd immunity in a cluster randomized trial of a polysaccharide vaccine. But more recent trials using conjugate, or a more recent trial using conjugate injectable typhoid vaccine did not find any evidence for herd protection. And of course, for rotavirus and cholera, we don't have any data because we don't have licensed injected vaccines. Okay, so just my last slide. What's the future for oral vaccines? So oral vaccines are currently the only technology known to induce true intestinal mucosal immunity. But injected vaccines may provide some intestinal protection, potentially through mechanisms such as transudation of serum IgG. If effective, injected vaccines do have favorable properties for inclusion into routine immunization schedules in terms of harmonization and cost effectiveness. And then finally, if we're to realize that benefit, we do need more experience with licensed injected vaccines against poliovirus and typhoid to inform their wider use and the development of new injectable vaccines. Thank you very much.
Okay, thank you very much for Professor Nicholas for your very useful presentation. And we will move to the next speaker. You can stay by Zoom. It's okay for you? Okay.
Yeah, that's fine. Yeah.
Okay. Yeah. For the next presented will be by Bu Hashta Meyta, Ministry of Health, Republic Indonesia, and she will give strategy and challenging in strengthening the vaccine coverage in Indonesia. Yeah. Okay. So this is the CV of Bu Meyta. She is the senior. Oh, yeah. She is the Senior AP Technical Officer of the Ministry of Health Republic Indonesia, and also she is the Head Secretary for Coordination and Integration Immunization Program and Gavi Focal Point Ministry of Health, and also the Steering Committee of the Link Immunization Action Network, and also she is the Lecturer of Pharmacology for Public Health Program at the College of Health Science, Rafflesia, Depok, West Java Province. 20 menit ya Bu ya, silakan.
Thank you Professor Mei. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, selamat siang, good afternoon. Okay, the previous speaker talks about the global polio eradication and also about the future oral vaccine. So we will explore how the immunization program in Indonesia, what is the strategy and the challenges. So could you please next? Oh, okay. My concise presentation consists of the National Immunization Program, vaccination coverage, challenges including best practices according to what has been listed in the National Immunization Strategy to 2025 up to 2029 and conclusions. For the National Immunization Program, Indonesia health systems. Okay. Indonesia health system is significantly transforming based on 6 key pillars. These pillars are foundation for improving healthcare system service, include ensuring equity and strengthening public health program nationwide. The 6 pillars of Indonesia health system transformation include the first one, primary service transformation, referral services transformation, health resiliency system, health financing system, human resources in health and health technology transformation. In this session, we will focus on the first pillar, primary service transformation, which includes strengthening immunization program as key public health interventions. And other pillar, such health security system transformation and health technology transformation have been adaptable and have made a good use of the development of digital technology, because we already introduced aplikasi Sehat Indonesia for the to support immunization services, and also Smile application to support vaccine and logistic for immunization programs. Okay, this one. Based on demographics, Indonesia comprise 38 provinces and more than 500 district or city, with more than 270 people living in more than 17,000 islands, and we have more than 1,300 multi-ethnic. And for income and socioeconomic, as we know, the GNI per capita was increased, and based on the World Bank data in 2023, the GNI per capita was 3,890. So Indonesia, no part of the upper middle income country, is not eligible for Gavi support, etc. And life expectancy was 63 years in 1990 and increased to almost 72 years. Since 2001, the administration of health services in Indonesia has changed dramatically. Managerial and financing responsibility for public healthcare have been decentralized from the central government to district level. And based on the Indonesia health profile, we have more than 10,000 primary health facilities, or we call puskesmas, to provide health services for more than 90 million Sp.A target across the Indonesia, where the number of surviving infant is 4.3 million children. So with over 70 million target received, Indonesia immunization program cover multiple population, including infant, children, adolescent, and specific adult group. And the goal is to achieve widespread immunity through life course vaccinations. Yeah, this is our national immunization program schedule to provide comprehensive vaccination coverage for children and specific population. And currently, we have 14 antigen are included in the NIP schedule, and we can see how time the immunization schedule is every month. In the immunization system, immunization services are provided at various points of contact in the health system, like puskesmas, posyandu, or we call integrated service post, school, and other immunization services, including public hospital and private health providers. For the immunization coverage, As reported in the joint reporting form, WHO and UNICEF published its estimate 2020 up to 2024, the coverage of like the BCG, DPT3, oral polio, IPV, and both measles coverage doses was still low. If we can see in 2020 up to 2021 due to the COVID pandemic. In addition, if we look at the data from 2023 and 2022, 4 and also still low because transition manual from digital for reporting and recording for the immunization programs. This one, the coverage for new vaccine introduction. Indonesia already introduced several critical vaccine like SBV, VZV, and rotavirus vaccine nationwide, and also scale up GE vaccination to endemic area. As commitment Indonesia for the polio eradication in 2023, Indonesia also switched IPV to second dose nationwide. However, the coverage is still low. The slide show like the SBV vaccination coverage already more than 90% each year. However, for other vaccine like IPV is still low. It decreased like in 2020 up to 2021 due to the COVID pandemic, and also when the health services and school were closed and restored. However, we conducted like the beyond national immunization campaign in 2020 to restore immunization in coverage. And so what the challenges? Even though the SBV vaccination introduction for the coverage achieve 90%, it means a successful school-based immunization program. However, the several new vaccine introduction is still low. So we use the WHO 6 building block to identify the challenges in the decentralized health system. Despite progress, challenges still remain, like limited funding, competing health priorities, and logistical issue at the subnational level, higher program implementation. Additionally, a factor like caregiver awareness, religious influence, and accessible impact vaccine uptakes. There are some challenges consisting like the governance. The challenges are the subnational coordination among multi-sector sector and implementation of immunization services, especially in the remote area or the hard-to-reach area, and the human resources. We still have challenges turnover health worker and inequity health worker distribution. For the immunization services, we fund suboptimal integration of immunization services with others program. For the vaccine logistic, we still have found reported vaccine shortage and stock out in the several level. And for the financing, we found a limited budget. So depend on the commitment, the local government to prioritize immunization program in their local budget. For in data and information, the transition manual to digital impacted quality reporting and recording. In several surveys, we found still challenges in vaccine hesitancy due to the misinformation, hoax, and negative issue, including the halal haram vaccine, something like that. Based on the Indonesian health survey in 2023, we found 47% of family could not obtain permission for immunization, and they worry about the IFI issue at first, even following immunizations. Another study found that vaccination refusal was due to the multiple injection. This one, what the factor, a variety of factor influence vaccine uptakes in Indonesia. We conducted several affecting childhood vaccine uptakes. Based on the Indonesian, we found that complete vaccination coverage increased with increasing mothers' education, and MOS collaborated with WHO to conduct BASD, Behavior Social Driver Study, to identify behavior. Specifically, it sought to identify belief, social norm, and practical barrier to vaccine uptake. We found that for 0.3% of religious leader support, and family health takes 66% of decision about taking off child for vaccination. In 2020, MOS 36 million children. Or we call S.Si, using multi-state cluster sampling to select randomly. We interview more than 2,000 household of children aged 9 up to 59 months in 5 provinces. We found that 46% of caregivers were willing to take vaccine as soon as they receive information from community health worker, or we call cadres. 20% from health workers, and 90%, 80% from electronic information education or EIC material, including the social media. And in last year, we also conducted a rapid convenience assessment during the polio national immunization days, or NID, and we found up to October 2024, we found that family, cadre, and religious or community are potential information as sort of information about the polio national immunization day. So what the best practices in the implementation national immunization program? Several best practices have strengthened our immunization program, such as phase introduction, because the last slide, we like the rotavirus vaccine and SPV introduced into 2021 for rotavirus. For SPV, we started introduced in 2016, and then after result for post-introduction evaluation, we scale up to others province and already nationwide in 2023. And also like PCV, we started introduced in 2016 in Nusa Tenggara Barat, and then after we receive what the effectiveness and then the evaluation of the program, we scale up nationwide in phased manner, and then nationwide in 2022. So the school-based immunization program makes vaccine more accessible to children by integrating vaccination services into a school environment, and also effective collaboration among various ministers, because we already have a joint decree between Ministry of Health, Ministry of Religious Affairs, Ministry of Home Affairs, and also Ministry of Education to support SPV vaccination program integrated in the school-based platforms. And we also adopted digital technology to provide real-time visibility into vaccine logistics, including stock level and storage temperature at various cold chain points. So this is our national immunization strategy that already developed last year to support immunization program in the 2025 to 2029. We collaborate with the University of Indonesia and also international partner to project cost and identify strategy to ensure that all immunization targets are fully immunized as the goal of the national immunization strategy. To achieve the goal, there are 2 strategies to ensure that all immunization targets are fully immunized. The first is strengthen immunization program management and governance at all levels. And the second one, increase high and equitable immunization coverage, scale up new vaccine introduction, and strengthening VPDs and IFI surveillance. In our national immunization strategy, we emphasize improving access to immunization services to achieve high and equitable immunization rate for 15 years old through the phase switch to hexavalent vaccine. Indonesia plan to switch from pentavalent vaccine to switch to hexavalent vaccination. It will be started this year in 3 provinces, and then will be nationwide in 2026. And also we will switch to 1 dose for SPV vaccination for 15-year-old. and then and also scale up to multi-age cohort to others girl for 20 up to 21-year-old in 2027, and continue scaling up to girl and boy at 11-year-old into 2028. We have been planning to use domestic product in patch manner for PCV and rotavirus vaccine, and will be 100% in 2029. Two new vaccines are listed in the national immunization strategy, like the dengue vaccine that will be introduced in the high rate head transmission area, and also the new TB vaccine. The introduction will be started in 2027. So we believe that the scaling up to multi-age cohort for SBV, and also reaching girl who missed SBV vaccination previously and switching to one dose will increase access, equity, and sustainability of the national immunization program. A new vaccine will reduce mortality and morbidity caused by vaccine preventable diseases. And at the end of slide, we can conclude that improving API capacity through health system transformation and demand promotion significantly improve access to immunization services. Commitment between local government, professional organization, community, and religious leader, including the private sector, is needed to strengthen the national immunization programs. Switching to local product will build trust and vaccine acceptance among community to ensure vaccine availability and sustainability. And we need to ensure the suspension budget is essential factor for the introduction of new vaccine to ensure the long-term success of immunization initiatives. Thank you for your time and attention. I look forward to your question and discussion. How can further strengthen national immunization program? Thank you.
Okay, so we come to our discussion session. Please take Bu Meyta to sit here, and also I still invite Prof. Nicholas. Are you still there in the Zoom?
Yes, I'm still here. Hopefully you can hear me.
Okay, so first I will give opportunity ask from the audience to ask a question, because I think both of the speaker is very interesting. Yeah, who will please raise your hand first? Who will? Masih ada? Kalau enggak saya tanya. Okay, because no, I will ask to you, Prof. Nicholas. Yeah. In the beginning of your speak, you already mentioned that there are some advantage of the oral administration compared to the injection. But in the last session, you also provide some alternative injectable vaccine, especially for the rotavirus and also the I think the typhoid that we already cholera, yeah. I think we already have. So what the reason behind that? Because you already mentioned about the setting and and maybe there is a transmission. So my question is there any possible like the OPV that rotavirus will also mutate to the wild virus?
Thank you. So the reason I was speaking about injectable vaccines as an alternative or as a complement to the oral vaccines is because as you saw, the oral vaccines do have lower immunogenicity, lower effectiveness in lower income settings where the burden of those diseases is higher. So those vaccines are having a huge impact and a huge benefit. But to address the residual burden, we're looking really for the next generation of injectable rotavirus vaccines. And in the case of polio, we actually have relatively limited experience in using the inactivated injectable vaccine to control transmission. And we have seen a recent recommendation in 2023 from WHO SAGE to use that vaccine more in outbreak response alongside OPV. And we also see countries increasingly having introduced IPV into their routine schedule, like in Indonesia with the 2 doses, starting to consider maybe going to a full IPV schedule or a hexavalent product and potentially eventually withdrawing the oral vaccine. So it's really in the context of those trends that I was talking about the potential for injectable vaccines. So far, I have to say I don't know the data very well on rotavirus strains and reversion of the strain used in the live rotavirus vaccine. So far, those haven't caused any problems. They can transmit from those who've been vaccinated to contacts, but as far as I'm aware, that level of transmission is very low, and we don't know of any circulation of a kind of equivalent to a vaccine-derived strain for the oral rotavirus vaccine.
Yes. So your question is about because the rotavirus oral is the decrease immunity due to the, like you mentioned, maybe there are some factor like the enteric disease, also malnutrition, and also okay. But the problem is.
Could I maybe just add that obviously with the development of the neonatal vaccine strain, the RV3BB, which is, Indonesia has played a key role in testing and now manufacturing. We don't have the data yet to say what the relative effectiveness of that vaccine will be in different settings, but it could well be a vaccine that's sufficiently effective that we don't need to look for alternatives, and it's certainly going to have a big impact when it is introduced.
Yeah. So like you mentioned that we already have in the phase 3 of the RV3 for the bird dose vaccine. And when I look for the publication that, because you mentioned that one of the factor that maybe influence the efficacy is the time of immunization. One that the delay the first dose will also favorable. But when I look for the RV3 effectiveness, so for the neonate schedule, the efficacy is higher as far as is 75% for the neonate schedule compared to the 50% from the infant schedule. So maybe what your comment? You still mute, sorry.
Thank you, sorry. Yeah, those studies that looked at a delayed dose were mainly looking at Rotarix with the 2-dose schedule going from like a 6 and 10 week to a 10 and 14 week schedule. I think there's something special about giving a neonatal strain vaccine to neonates that may have some benefits. I don't know what the data you're quoting there is, and I have to say I've kind of forgotten the data that has been published on RV3. I don't know that there were big differences between the 2 schedules or if they were significant. But yeah.
I also look for the publication. The publication in the.
Could I maybe ask a question to your colleague from the ministry about the plans for the introduction of rotavirus vaccine? What's the current product and what's the plan in the longer term?
Bu Mita, silakan.
Thank you. For the rotavirus vaccine, Indonesia introduced firstly into 2021 in 183 districts, and then nationwide in August 2023. However, we still have challenges, even though the rotavirus vaccine is oral administration doses, because if we look at the coverage in 2023 also still low, and 2024 also still low, because if we look at the product licensing by Indonesia and RA, the rotavirus vaccine is given in infant is the strict age window. Depending on the brands use it, like in Indonesia, in national program, we use it rotavirus vaccine from Barat, Rotavac, and the first dose must typically be given before 15 weeks of age, and the final dose is completed by 6 months of age. So if infant has not started the vaccine series by the cut of age, so they should not receive it later because concern about the increased risk into subsections. So do you have any experience from others country because the strict X window for the rotavirus vaccine, even though for the oral administration dose?
Yeah. Because also I will ask you, because when we look for the WHO recommendation that in the WHO position paper that there is no limit for the age. So as far as I remember that maybe if we prolong the age time limit, so we can prevent 200 or something death, but for one increase of the interception. So what do you suggestion?
I think I agree with you. There was that initial age restriction to administering beyond, I forget, was it 9 months or 6 months?
6 months.
That it was recognized that lifting that upper limit would actually still save lives. So as far as I'm aware, that's still the recommendation.
Okay. So any other question? Pakai nama ya. Sekalian. Dan juga ditujukan ke siapa ya? Baik.
Okay, thank you for this golden opportunity. So my name is Abelia. I'm from the International Federation of Red Cross and Red Crescent Societies, and also working really close with the PMI. So my questions is coming from the challenges that we face that already presented in Ibu Hashta presentations. So we know the coverage of immunization in Indonesia for polio is very low. So what if, so there is a scheme in my head because PMI PMI has like very big desk network volunteers that can be strengthened, and also community health workers is already involved in polio vaccinations program. So why we don't like do this giving incentives to the community health workers or the community volunteers who can find the children who hasn't received the dose of polio vaccination yet, instead of responding to the polio cases that already worsen. What if we do like the cost benefit analysis, doing the before intervention, the prevention intervention, instead of doing response of the polio cases that already worsened? And also, is there any initiatives from the Ministry of Health that points to strengthen in the community level? And maybe that's my question for Bu Hashta. Thank you very much for the opportunity.
Very nice questions.
We collaborate with UNICEF Indonesia and also other international partner in country. We use the human-centered design approach, use a focus group, and we do the community dialogues, and also involve like the religious leaders in the community. And currently for the SCD process already introduced in 14 districts, and we can see like the Aceh province previously before the SCD process implemented, the coverage is low, especially not only for polio and also for DPT. And now like the PD Jaya district, they already changed their services following what the human-centered design recommendation. And if we look at their coverage during the National Immunization Polio Day, the coverage is more than 90% now. So we also in community, we also have challenges about the IFI issue adverse event following immunization, and we engage with the National Committee for IFI to do the live verification, and also collaborate with the international partner to develop the information education information and communication material, and we adopted in with their local language, and then share to social media in their environment. So it's very impactful, and we plan to scale up the process to other provinces.
Okay. Any question? Oh ya, silakan. Yang ya, mbaknya dulu. Ya, ibu-ibu dulu. Ladies first.
Thank you for the opportunity. My name is Mentari. I'm from Center for Health Policy and Management, VKM. And my question is addressed to Ibu Hashta. So this is just a personal curiosity. So with the recent changes in the health financing landscape in Indonesia, which is driven by both the external and also internal influences, to what extent do you think those changes would affect the rollout of routine vaccination in Indonesia, probably in the more shorter terms? Thank you, Ibu.
As we know that Indonesia has the decentralized system, so sometimes we cannot intervene what the regional decisions. Like at the national level, we develop a technical guideline for BOK, health operational costs, that included immunization in the menu priority. So we hope if immunization program already listed in the technical guideline for operational costs, so will be costed and secure. So depend on the, so it's very important how to advocate the local government, what the importance of immunization. Like the polio 2 years ago, to respond the polio outbreak, we conducted national immunization program covering targeting for more than 35 million children, and we spent money. So this and then we coordinate with the multi sector and also involve the interministerial, like the Ministry of Home Affairs. They circulate official letter to all governor and mayors to improve do and also support government for the national immunization program. And then for the result of outbreak polio response assessment in 2023 for like the Aceh, and we conclude that the result of the polio coverage is more than 90%, and then we still awaiting the others result of outbreak polio response assessment in the 27 provinces.
Okay, thank you. Is there any question? Oh yeah, silakan.
Thank you for the opportunity. My name is Ramarganda Simanjunta from Rio University. I would like to ask the Professor Nicholas actually. So you explained previously that this oral vaccination could induce the immune system in mucosal level, especially in the gut systems. But my question is that could this oral vaccine efficacy could be impacted by the gut microbiome systems? Because the gut microbiome system is also a part of this gut system that modulated the immune by the short chain fatty acids. So is there any research or probably a future research about this gut microbiome could enhance the efficacy of the oral vaccination? Therefore, and probably to enhance this oral vaccination, we need to adjunct some kind of probiotics or probably symbiotics. And what's your opinion and perspective on that? Thank you.
Thank you. Can I go straight to answer that?
Yeah. Okay, go ahead.
Great. Yeah, thanks. A really nice question. So there have been quite a few studies looking at measuring the gut microbiome and trying to correlate presence of different bacteria with the response to these vaccines. Those studies have tended to typically find not strong associations, and where they do find associations, it's been hard to replicate those, mainly because you're measuring such a complex microbiome. Often you might find an association by chance, and then it's very hard to replicate that. So those observational studies don't provide very strong data. Where perhaps you can start to modify the microbiome and look at the effect on oral vaccine response. That's where I think you can start to generate the data on the relationship between the microbiome and oral vaccine response. There have been a number of studies using both probiotics and antibiotics. I don't really have the time to summarize all those studies. There is some modestly encouraging data for probiotics having a beneficial impact on oral rotavirus vaccine immunogenicity. Studies that have disrupted the microbiome using antibiotics have not affected vaccine response. And perhaps, as I mentioned during the presentation, the strongest evidence for the microbiome being important is actually the virome and co-infection with other enteric viruses and pathogens that probably tickle the immune response, induce an innate antiviral immunity that is effective against these live attenuated vaccine strains. So it's a great question, and I think it's an area of ongoing work, but quite challenging work.
Okay, thank you, Prof. Nicholas, for your answer. I think because we are already in the end of the section, yeah. Sudah selesai, dah habis ya. Is there any question? No? Oh, one more. It's okay? Yeah, short question. Yeah. Silakan.
Cek. Okay, thank you so much for the opportunity. My name is Komang Gede Setiawan. I'm from the Center for Tropical Medicine, Universitas Gadjah Mada. I would like to address my question to Prof. Nicholas. I hope I'm not missing some of your presentation, but I would like to know that oral vaccine have played a critical role in controlling polio, rotavirus, and also cholera. Yet their immunogenicity and effectiveness vary significantly across different settings, such as in low-income and high-burden countries. What are the primary factors influencing this variability? And also, is there any innovative strategies or intervention that show most promising in enhancing oral vaccine efficacy in these regions? Thank you so much.
Okay,
Yeah, thank you.
Sitaresmi.
Yeah, I think it relates a little bit to the previous question as well about what might be the mechanisms driving lower immunogenicity of vaccines in high burden settings, and what might be the interventions available to us. We talked just now about the microbiome and the use of probiotics. That's one strategy that could be considered. Also, other strategies are changes in the immunization schedule to either offer vaccine in the neonatal period or later in life. Also, administering additional doses. But as I showed on one of my slides, the summary of interventions that have been put in place to improve oral vaccines have mostly not really had much of an impact. And it's a very challenging field. It's very challenging to try to improve oral vaccines. It's something I actually spent probably about 15 years of my life trying to do, and are now moving away from trying to do that because it was so difficult. But I'm sure someone clever in the room might be able to address that problem.
Okay, still hard work, yeah, to improve the immunity from the oral vaccine, yeah, especially from the developing country. Okay, so thank you very much for Professor Nicholas and also Bu Mita for very nice presentation. And before we close our session, so would like to summarize first from your Professor Nicholas that you mentioned that oral vaccine are currently the only vaccine that known to be introduced mucosal immunity. However, the efficacy will reduce various among countries, especially from the high mortality countries. So decrease due to some factor and some strategy already be done, but unfortunately until now there is no evidence that this strategy improves the immunity. And you mentioned that maybe injectable vaccine may the alternative or complementary from the oral vaccine. Yeah. And from Bu Mita mentioned that the coverage of vaccine, especially for the new vaccine, is still low. There are some factors from the human resources, from the logistic, from the financial, and also from the demand side, like as a destination. So we have to work together to solve the problem. So advocacy from the finance, especially from the not only from the national level, but also from the district, the province, because you mentioned about the decentralization, and also how to advocate, also involve the community, such as a community leader, and also religious, and also from the other sector, not only in the Ministry of Health, but also from the other ministry, to combat this issue. And also you mentioned about how we have to improve our capacity to produce our local vaccine, because I also shocked that hepatitis B is also still imported. So that's why we have no pentavalent due to no hepatitis B. Okay, so I hope that the Bio Farma will also improve capacity to produce the local vaccine. Okay, thank you very much for all of you, for both experts and also for all of you. And I hand over to the MC. Thank you. Thank you, Prof. Nicholas.
Once again, thank you very much, Professor Grassley, Professor Alonge, Professor Hashta Meyta, and Professor Mei Neni Sitaresmi for the second symposium, Challenges in Vaccination for Strengthening Resilience Against Tropical Diseases.
Yes, that's so true, Rima. And we still have a lot of agenda for the first day of this year conference. And after this, all the participants can enjoy the poster presentation session. And the session will be held on the Graha Wiyata Hall.
Exactly. At the Graha Wiyata Hall, that is a building over there. Oh, I see someone there. Thank you for joining. And then we will have the presenter as well to explain about the poster. So you may ask the presenter a lot of questions regarding the poster and even make a networking there.
Yes, of course. And at the same time, you can enjoy the refreshment and coffee that already prepared by the committee until 3:35. And after that, we're still waiting for you to join us in this auditorium.
Yes, we still have 2 more exciting agenda right after the coffee break. So 3:35, once again, dear ladies and gentlemen, 3:35 kami akan menanti Anda kembali lagi di ruang auditorium FKKMK UGM. So my name is Rima.
My name is Yopi and enjoy your rest time.